haven't done that. All right, let's get started. So I have no disclosures. And really, today's topic is an interesting topic. It's a topic called appearance versus reality and expanding the frontiers in neuromuscular medicine. And I found this quote saying, "Things are not always as they seem. The first appearances deceive many." And that's going to be the theme of our talk. And the background of this talk was actually during a dinner conversation. I have a great team here. You should see Ashley Hayden. She's the director of our Neuroscience Institute. We have Dr. Smith, Steve Smith, who's the chief scientific officer of our Neuroscience Research Institute, and Rob Herzog, who's the vice president of our research institute. And, I was having dinner with Dr. Smith, and he said, what motivates you about neuromuscular medicine? And that was the moment, that aha moment, that I was like, wow, what motivates me is the fact that there's this appearance versus reality. And that's a theme we see everywhere in literature and human beings. And, if any of you guys have eaten food, it may look good, but it doesn't taste good. Or food that doesn't look good tastes great, right? So there's a difference between appearance versus reality. We see that in patients all the time. So appearance is the way we see something, and we use our senses to gather information, but unfortunately it's deceptive and misleading sometimes. And the reality is the state of things as they actually exist, or something's true state. It's not really understood by the senses, and it's more genuine. So what my passion is, as neuromuscular physician, with patients come from all over the country, is that they tell me these things: I can't work, I don't feel well, I feel tired, Dr. Jared, you're my last hope, I have so much pain, I don't enjoy life anymore. And some of them just say, I don't know what's going on. And my job is to take that appearance, they're really not feeling well, and just say, is this neuromuscular? Can we treat it? Out those hard cases. That really does motivate me. And that's what this talk is about. So many neuromuscular disorders, if you guys have seen them, they're just challenging. Histories are unclear. The pathology reports can be negative or maybe sometimes confusing. They really don't give us much, right? And then sometimes the nerve conduction studies and the EMG testing just don't show anything. And the lab tests are unveiling, the exam is normal, and sometimes we're dealing with genes that are just completely undiscovered. So my passion is to take those patients and to say, okay, when do we go further? And usually it's the patient's complaints. And it's frustrating, it's challenging, but their complaints are just much more than the findings, and they really are not able to do anything. Yesterday, I had a patient who was lying in the EMG room and just saying, Dr. Jared, I cannot get up from bed. He cannot move, although he's muscular, he's fully strong, and you're just looking at him, he has so much pain and muscle pain. Those are very challenging, very hard cases. So let's get started with some of the cases that have this sort of appearance versus reality issue. So case number one is a patient with left shoulder spasms. A 32-year-old, healthy, very intelligent gentleman came into my clinic and said, Dr. Jarrett, I have neck pain and left shoulder spasms. So as a result, in the past, he got a surgery, cervical spine surgery. And as soon as he had the surgery, started having left shoulder weakness. So what happened was that, he started to develop a little bit more. He started to have weakness, and then he started having his twitching in his, left arm, then right arm. And the doctor locally diagnosed him with benign fasciculations. He continued to have neck pain. And anybody can step in, they can join in and say, Doctor, I think this, I don't know what's going on. Or you can just say, look, did you check this? So I'm open to the interaction, even though they're virtual. But, just to think about this, our initial appearance, especially given the previous EMG report, was benign fasciculation syndrome and everything related to a cervical spine surgery. So you're just like, okay, well, 32-year healthy guy, he probably had surgery and now he's having this little bit of weakness and he has fasciculations throughout. But what's really important and what kind of separates us in our neuromuscular world, and I don't know how each one of you who are physicians or see patients, how you deal with this, but the physical exam is so important. And in this guy, and I know patients make fun of me, like, oh, Dr. Death, are you really going to be able to test my strength? I'm like, yes. So after thousands and thousands of patients that you examine, if you get just a subtle weakness, and I do, and I split hairs on it, but if I can actually, they can't resist me, even in kids, there is something wrong in some way. I really do categorize, I really do think about it and take it seriously. So on his exam, he had this very subtle intrinsic hand weakness. He had some weakness in his external rotation on his left and some weakness in his left deltoid, just very, very mild. And he didn't even realize he had tongue weakness. So I got him a little bit worried, and then his reflexes were brisk. So already we're starting to think there's something wrong. And then we did a repeat EMG, showed fasciculations, and finally he came out with it that his dad had ALS. So now we're doing genetic testing. I would have done it anyways, but he had a very interesting pathogenic variant in the CHCHD10 which is a more rare gene for ALS, but it's associated with FTD and ALS, and its basis of this mutation is actually a problem with the mitochondria. So for those that are interested in the basic science, it's a mitochondrial issue. But the big picture here is that this is an appearance versus reality. You've got someone who comes in, 32-year-old gentleman, healthy, active, working, and he says, oh, I have left shoulder quivering, but really he not only just has ALS, but he has a rare gene mutation in the CHCHD10 gene. So there's a lot of layers of discovery here. And as the Dalai Lama says, appearance is something absolute, but reality is just not that way. Everything is kind of interdependent and not absolute. So our teaching point to get from the esoteric to the more common stuff is that if you have fasciculations in the clinic, so fasciculations are caused by a nerve just firing on its own. It's doing its own thing, and the muscle just kind of twitches away and does its own thing. Usually, if they don't have weakness, that would be anxiety, caffeine, thyroid deficiency, magnesium deficiency, stress, fatigue, age, even anticholinergic meds. And I ask them all these questions, hoping it's not something like ALS. But if they do get weakness, then you start thinking about neuropathies, motor neuron disease, and a whole host of differentials. So don't forget the common stuff, but it's also important to recognize that when things can get serious. All right, case number 2 is a patient with severe back pain. So another 32-year-old gentleman. So if you're 32, try to stay away from my clinic. I'm just kidding. But another one who came in, he had, oh yeah, Dr. Lee, do you have a question?
Yeah, so, this is something that I'm really concerned. I mean, I've been here for 11 years now. So what happens when I'm in other state, in other academic institutions, when someone is considering a spine surgery, especially spine surgery, usually they get neurology consult before they do surgery. In Central Florida, it doesn't happen. It's usually just one-way decision by neurosurgeon, and I think probably I've seen at least a few patients who in retrospect didn't need spine surgery and nevertheless just got them. So I think that's something that you should be aware. There are a lot of patients without any EMG or neuromuscular evaluation they get spine surgery, essentially futile surgery.
Oh my gosh, I could talk to you for hours about this. On a Friday afternoon, I would keep you here. I absolutely agree. Our surgical teams really are very surgery friendly, and I think that that's something that we need to improve. I had a patient with CMT, or Charcot-Marie Tooth disease, the hereditary neuropathies, and a surgeon, without even consulting me or knowing, she had clawed hands. He just wanted to release the nerves, which are already damaged, and that's not even going to help her. So there's a lot of surgical readiness here. And I think that maybe those are some protocols we can always improve, and get that neuromuscular, team neurology input early on, because definitely I don't think surgery was warranted. And in fact, I don't know if after surgery it kind of triggered the process of weakness, Yeah. So I agree with you. All right, so case number 2, this is a patient with severe back pain. So this is another 32-year-old gentleman, and this guy just came in with this occasional numbness in his hands. And what was interesting was he had this, transient biceps weakness. Who knows what that was? He said he was stretching somewhere, and he, doing some sort of movement with his arms and just got weak for a short amount of time. When I saw him, didn't really make much of it. And then he had this severe back pain, which was really interesting. Like every time he woke up in the morning, he had severe pain that kind of was jolting and stiffness. Since he was a little kid, he couldn't sit down in the car for a long time. He couldn't even sit down in his chair. And he was just constantly stretching, constantly unbearable pain his whole life. And he had no numbness, no saddle anesthesia or bowel bladder dysfunction, which are red flags for a spinal cord issue. And, just kind of disabled by this back pain. And then what is our initial appearance? He had this chronic low back pain, right? And the testing results and next steps. So we were thinking like, look, this is just chronic back pain. Who cares? But he had an EMG and nerve conduction study. It was really interesting that for the biceps weakness, he really had a musculocutaneous neuropathy. He had bilateral and median neuropathy and kind of a symmetric neuropathy everywhere. And he also had problems with his spine. He had severe bilateral neuroforaminal narrowing. He had a disc bulge with severe left and moderate right neural from. So he had some stuff in his back, he had neuropathy. If anybody wants to jump in with what they think this could be, and then we'll go to the next slide. Anybody have any suspicion? You guys have any thoughts? It's not. It doesn't sound like it's chronic low back pain.
Could be some sort of hereditary neuropathy.
Yeah, absolutely, Dr. Lee. I'm going to tell you, the last time we gave talks that you were answering all my questions. So absolutely. There's a specific one. And, I just thought about this because, he had the PMP22 deletion for hereditary neuropathy with liability to pressure palsy. And so really in those cases, surgery is not recommended because if you do have the neuropathy and you do have any sort of prolonged position, they can have prolonged weakness. And so they can have a compression in their nerves, and that's not good. But the great news is that we remarkably helped in finding this diagnosis. I sent him to pain clinic where he received epidural injections, and he's gotten so much better. He's never had pain relief in his life. And I was talking to him while he was traveling in Atlanta, and he was just, they miss my appointments because they're having so much fun. But so these are HNPP is a neuropathy that patients are born with, and when they have a compression, like they compress their elbow, they cross their legs. Some of my patients said that when they carry groceries, they'll have a wrist drop for just a day. Nope, they think it's normal, but it's a disorder affecting the nerves. They get this transient weakness whenever they compress the nerves, and sometimes the weakness can be severe, sometimes it can be mild. They can have these high arches or pes cavus. And again, I said it's transient, so it just lasts for a short amount of time. Although some people can have weakness more longer, depending on what happens to them. For example, if they have surgery, they're going to have a prolonged weakness at sometimes. Usually, their quality of life is great. I think in this guy, the back pain was triggered mechanically. So every time he sat down, he was having severe back pain. What happens is these nerves, so when they compress, they form this thing called tomaculae, and they actually have the swelling of the nerve, which interferes with the nerve transmission. So that's when they get the weakness or the pain. It's rare, but it's just, I think it's under-recognized because people are mild and they're variable. They have variable symptoms that come and go in variable presentations. And, lo and behold, we have a poster that we presented because we had two patients, interestingly, both with HNPP, both presenting with back pain. And so that's what I thought was interesting. And the back pain for both of them is positional. And one of them has gotten the epidural injections, the other one hasn't. So the other one still calls me, but we're getting her there. So it's just important to realize that these are kind of new entities. It's pushing the frontier of neuromuscular medicine. People present with these kind of symptoms of positional back pain, but perhaps it's hereditary. Perhaps there's something more underlying. And this is one of my favorite quotes: sincerity means that the appearance and the reality are exactly the same. So we're trying to get there in neuromuscular medicine. Patient with tingling thumbs and toes. She's a 67-year-old woman. I don't know, she drove 5.5 hours to come see me, so I already know something's going on. She was unathletic as a child. She presented with tingling in her thumbs, hands, and feet. But other than mild tremors, there really was nothing else. I mean, she had an intact neurological exam, and her EMG and nerve conduction studies are normal. Her dad had a neuropathy, but let me tell you, she brought in 3 binders of all the labs done. I mean, this is just a snip of it, but she had everything done. So nothing came back positive. And, she had come to see me because she knew something was wrong. And her local doctors just thought she had anxiety. Because you got her EMG is normal, her exam is normal. I think the only thing she had was absent Achilles, just complaining of pain in her hands. Like, what? And nothing is coming back. They really did an extensive. And so what happened with her is that I did the genetic testing, and she had this GDAP1 mutation, a heterozygous pathogenic mutation, the GDAP gene responsible for CMT2K. That was the same mutation seen in her dad and in her daughter. And you can see that it ended up getting to be published. We just got this published last week in Case Reports in Medicine. So that's great. And you can see that this chart, I know it may be hard to follow all these testing words, but this again is one of my passions. It's something that I like to push the envelope and push the frontiers. These are patients that come in with very few findings, but a lot of complaints. There's a lot of pain in the hands. There's a lot of pain in the feet. Sometimes their EMGs are normal or just like a borderline. Like you'll see sometimes the sural is abnormal, but everything else is perfect. And the exam is intact, but they're wanting disability. They just are so disabled. And when you get into these kind of differences, and they go from doctor to doctor, and the doctors think they're crazy. Nobody understands what's going on. This is what this chart represents. It's these patients who have these unexplained neuropathies, and they don't have an answer for them. And that's really what motivates me. So this appearance is real. They appear like they're crazy. They appear like they've got nothing wrong, but really they have something wrong. So that's an important part. Oh yeah, Dr. Lee, go ahead.
So when you deal with this patient, obviously we always try to find some objective testing like in nerve conduction study or EMG, and it's negative. Then do you throw genetic testing to everybody, or how do you make a decision? If you decide to do genetic testing, is there a specific gene panel, or you do run a whole genome?
Absolutely. No, it's a specific panel. We have a neuropathy panel for with Invitae. So the Invitae
Okay.
test topic just focuses on the neuropathy panel. And so when they do come in, I do tend to do this because this is one of my passions, is to kind of discover the undiscovered. And when you have somebody who comes in with just really minimal signs on exam, but major complaints or in general have some suspicion of something wrong, I do tend to lean towards the genetics. So, but there is a panel.
That's great. Thank you.
Oh yeah, thank you. So I just love this. And what we did find in this paper, which was really nice, and not that it wasn't explained before, but it wasn't even explained at this level, that we just have tremendous amounts of pain in these patients with the GDAP1 variants. Now, if they're homozygous, they're very severe. They're a different type of CMT, but if they're heterozygous, you get a very mild version, and they're late onset. So a lot of our patients, they didn't have symptoms till after age 40. And it's something that you don't think of in a CMT patient. All right. Let's move on to something that's more common and get you all into some rare issues and rare patients. But when all of you are in the clinic and you have this patient, you can definitely send them to me. But for those that see general and they see patients with pain and tingling and numbness and say, oh, how many times are we going to send them to Dr. Jareth? Or, definitely send them over. But the baseline workup, and this patient I could get to where we got to was because she had already had tremendous amount of workup. She had 6 binders. She had, I believe, got to University of Miami. She had different places she had gone to. And when you have that background, that can help launch to the next level of the hard cases. So for those that don't know, we have a very, very nice neuropathy hack. It's a neuropathycommons.org website. So so you can go on there, and I really like this checklist. You don't have to do all the labs here, but at least you can get a baseline of labs for small fiber neuropathy and those that are acquired causes. So, we definitely did this in this patient, but for those that are just, practicing and, on the fly, you've got a patient with burning pain in the feet or something, just has pain, numbness, and you think of small fiber, make sure you check these labs. And this is a great website for any sort of reference for how many labs you want to do. All right, so this patient also had appearance versus reality, like the theme of our entire talk. She had tingling in her hands. She had a normal study and exam, and the genetic testing revealed CMT2K. So just like you see this Instagram picture, this is what a lot of physicians think. Oh, there's nothing wrong. This is anxiety. She's crazy, like she doesn't have anything obvious. Her EMG is normal, her exam is normal, but in reality, she's having lots of pain. She can't do the things she used to do, and she really has some underlying form of CMT. So our next patient is a patient with numbness and cramps all over. Around age 26, she developed numbness in her left big toe, her face, her fingertips. Her symptoms were worse with activity. And prior to these symptoms, she was very active, and she was teaching acrobatics 30 hours a week. So that's a big thing in our neuromuscular clinic, is that when somebody's going from 30 hours of acrobatics to 0, that's a red flag right there. Like, that something's wrong. But she started having pulmonary embolisms, a diagnosis of psoriasis, joint muscle pain, numbness, and cramps, and just weakness all over. She's trying to walk. She needed to use an elevator. Someone who's teaching acrobatics had to lean on a car. Just had no strength. And, when you ask her, she really was not athletically. She didn't like running her whole life, but, really not much to make of it as an issue. So we did her neurological exam. It was intact. Again, one of those patients where you take a deep breath and say, oh, what is this? And a lot of symptoms, really nothing defined. And, my brain felt like this. Honestly, like, I never forget when I see these kind of patients, I really am interested, but they take a lot of energy because you have weakness and you have numbness. And where do you localize this, right? So if anybody has any thoughts about it, definitely raise your hand and let me know if you're having any thoughts or any ideas about what this may be.
Well,
Yeah.
so Eva, I thought, someone has a history of pulmonary embolism. That's probably life-threatening. Maybe that's where I would start. What kind of disease can cause neuropathy as well as embolism or coagulopathy, or you know what I mean?
Yeah, and Dr. Lee, I think I'm going to stump you on this one. This one is hard because we're actually going to do the research on this one. But you're right, the pulmonary embolism was the first clue. And that threw me into like doing that CT chest, abdomen, pelvis, just like figuring out, is there some malignancy screen? What am I missing, right? Because why would she have that pulmonary embolism and then she had numbness and she had weakness? And on top of that, I think a paraneoplastic panel was done. So we'll go ahead, but it was just so hard. And I agree with you that pulmonary embolism was that life-threatening, that first step. But anything else, this is going to be a challenge, I think. Just know where to really localize it. And you could see that she had all kinds of blood work done. I did everything. And that, we did an EMG, it showed neuropathy and myopathy. And it was interesting because her genetic testing was positive for a Duchenne deletion, a pathogenic variant. And so, as all of you may know, like, Duchenne is seen in boys. And this, but in this case, females can be affected. And so what we're doing is that looking into all the women that have a Duchenne deletion, and I don't know where the pulmonary embolism stands. I don't know where her numbness stands, but that's where we're looking into it, because perhaps, this deletion may be associated with some things we don't know about. But what we did, our patient had this like whole array of symptoms. And, despite all the tremendous workup we did, we were able to find something. But what we found is actually on the newer realm of research. So what we found, and then we did some digging up, and women who are carriers of this Duchenne muscular dystrophy, they have variable symptoms. Some of them will have like upper extremity weakness, some will have lower extremity weakness, some will have IQ abnormalities, some will have slowly progressive weakness at a variable age. And so we want you to stay tuned. We are doing research on this, and we will be keeping you posted for anything we find. But I think that this was a case where we were all over the place, and until we actually focus, I did a shotgun approach, but the genetic testing helped us in some way give some answers, not all answers, but some. Any thoughts on this case? This is a hard one.
So because this is X-linked, did she have any child that or cousins or nephews or who has DMD?
No, not that. She is the one that did not have any family history of it. Not that I remember.
And did you check other family members?
I think we're in the process of that. I don't think anybody has it in their family.
Okay, all right.
So yeah, that's interesting. So, and I wonder if Dr. Lee, it's because the boys don't survive. So maybe and I think she just has women, daughters. So I think that a lot of times in these cases, they have girls. But I think we are looking into that. And she's interesting. She just doesn't have the family history. It would have been easier. Oh, look at Jennifer. Thank you, Jennifer. 1/3 of Duchenne mutations are de novo. Thank you. From Jennifer Pagano, our genetic counselor. Thank you. And we are working on that paper right now. So. All right, so very hard cases, and going back to our theme of appearance versus reality. I don't know if any of you guys read Hamlet. I'm a big Shakespeare fan when I was a kid growing up. And Hamlet appears to be insane in the play. However, in reality, he pretends to lose his mind to conceal his true intention. So he acts crazy, but he really isn't. And it's the same thing with some of these cases. This patient looked crazy. She had numbness all over. She had muscle cramps. She was like using an elevator when she was an acrobatic teacher for 30 years, and you're just like, wow, what a problem, and she ends up being a carrier for Duchenne muscular dystrophy. So in reality, we have to, that's where neuromuscular medicine is heading towards. How do we get from that appearance to the reality? All right, so we have another patient. This is a 39-year-old man who drove from very, very far to come see me, and had colon cancer. He had multiple episodes of paralysis after chemotherapy, exhaustion, brain fog, nausea, and variable weakness. And, what's interesting is that when you go over the history over and over and over again, he keeps saying, this is all after his chemotherapy. And so he said, okay, when it's worse in the morning, triggered by exercise. And I remember trying to get him to say, what is that one thing he loves? And that one thing he loves is whitewater rafting. And he couldn't enjoy it. He couldn't do it. And you're just looking at him like, he's sitting in my clinic. He drove here from, the Midwest, and he cannot go whitewater rafting. I really don't understand. It's mind boggling that these patients just feel like they can't do it. And he's sitting in your clinic, and you feel like they can do it, but they can't. So you try to get an understanding. He said, like, every time he moves, he gets weak. Like, he has, if it's cold, if he's hot, he's stressed, he's excited, he has too much salt, too much potassium, not enough potassium. And he's squatting, he just cannot do what he wants to do. And unfortunately, these patients, when they see you, their exam is intact, they just say, oh, I'm tired. So again, your appearance is like, it's frustrating because they don't have anything focal. They have no leads on anything that they're telling you, and they have binders. This guy came in with like 6 binders of information. It was obviously his last hope. So I was like, like going over your whole history over and over again, and I haven't given you the workup, but initial appearance was like, is this all due to chemo? Like, after he had chemo, maybe he started getting weak. But, he had extensive workup at Mayo Clinic. and his EMG nerve conduction showed positive long exercise tests, which they started saying, okay, that's significant for periodic paralysis, but they couldn't figure out the gene. They did genetics. We did our genetic testing here, and we found an MCM3AP variant, which is actually one of the newer genes for periodic paralysis. So again, we're doing research and publishing this. We have another patient with the same variant. And what we ended up doing was, instead of focusing on chemo and, putting him on, prednisone for an autoimmune response, I didn't know what he had. I ended up just focusing on his potassium and adjusting it to an optimal dose, which really, really helped improve the quality of his life. So he's been doing reasonably well. And I just, these are really hard cases that you have to actually push the envelope and move the field forward to understand and diagnose. And so appearance versus reality, he had this variable weakness after chemo. That's what it looked like, but it really in turn was periodic paralysis. And so you can see how this fruit is covered by gold, but really inside it's rotted. So really it's important to decipher what's figuring out. This guy may look like he's muscular, he can be doing whitewater rafting, but every single thing is triggering, episodes of weakness. All right, this is our last case. So we are moving along with time and, hopefully get you out of here so you enjoy your Friday afternoon in April, enjoy the rest of the day. So this is our last case. This is a hard case because this is a boy with muscle cramps that had to skip school. So this is a 22-year-old boy. And again, you're all over the place with symptoms. He's numbness, he's tingling, he's fatigued, he's pain, he's difficult sleeping. And my mind is just going all over, like, what is this? He started having fatigue in 2017 and has not been the same ever since. He was taking walks consistently, but just noticed that he had endurance difficulties. He could do the hike, but it would be physically taxing. And so, I did his exam, and this is the one clue I got. Like, I made him do squats, and I make all my patients do squats, and he had this like touch of weakness, maybe just like very slight amount of weakness. It's hard to detect because it lasted briefly. His exam was intact and he just had severe pain, and it really bothered me. For a 22-year-old kid, just to miss college, and he had really, you're just like, okay, you can get through this, right? You can get to college, you can get to your classes, you can focus. And he said, Dr. Jarrett, and these are phone conversations I had with him after our visit. I said, why is it that you can't go to school? I can't understand this. He's like, every time he goes to school, he feels like he's tired. He's distracted with his pain. He can't get to classes. He's so fatigued. And I'm just like, you look fine. There's nothing overtly wrong with you. It looks like some fatigue on exam, but, that shouldn't interfere that much. And so local doctors were like dismissing him. He went again from doctor to doctor. And again, he was thought to have anxiety or sleep. So they were focusing on that. And I just was like confused. So I did, an EMG nerve conduction. And again, I'm trying to split hairs because we're trying to get him back to school. And he had a mild sural nerve abnormality. What do you do with that? And fasciculation is the left deltoid. That didn't really pinpoint anything. Of course, I sent to neuropsych. I said, he's got this chronic pain. Should he go to sleep disorder specialist? And I even did the genetic testing. I was like, gosh, we got to get genetic testing. You know how much I love it. And that came back negative. Unfortunately, I was like, gosh, this is a hard case. He could just continue to have muscle aches, muscle fatigue, muscle cramps. They call a lot because there's so many symptoms, but really just no answer. And then I did a myositis panel, which I wasn't sure, but it showed up that he had the anti-Me2 antibody positive, which to me made a little more sense because, this is a subgroup of patients that just have this really not too many things going on. They have low interstitial lung disease rates. They don't really have that. They don't have malignancy. It's variable weakness. They can have very mild symptoms, but their treatment response can be very good. So I was like excited to find something, and he was really grateful too, and is getting much better with all these steps. So appearance versus reality, muscle cramps, pain, difficulty sleeping, fatigue. It looks like he's got a lot of anxiety, but he really has, in some sorts, myositis or inflammation of the muscle. So just like you see this, Little Red Riding Hood thinks that this person's being an angel is really a wolf. So we always, what appears to be something may not in reality be what we think it is on the first glance. All right, so thank you very much. I know this is a relative, a little bit of a shorter version of my talks, but just cases that are very challenging to diagnose and kind of what puts us on the frontier of neuromuscular medicine. If you have any questions, don't hesitate to email me. I have my cell phone here. For those that are unaware, we've got clinical trials for ALS, CMT, SMA. We are an MDA care center, so we have big programs that we run. We're just grateful. I'm just so grateful for our team here, as well as our, amazing neuromuscular clinical administrative team. Just cannot run such a big clinic. All of my colleagues. So let me know. Does anyone have any questions?
Well, I don't have any question, Yvette, but I think whenever I listen to your talk, I'm just amazed by your passion and the knowledge and curiosity about unknown, trying to make diagnosis of very difficult and challenging conditions. So, and I'm very grateful that you're practicing in Central Florida. I mean, before you came, literally a lot of these patients had no place to go and probably considered crazy or, psychogenic or whatever, you know what I mean? So thank you.
Oh, thank you, Dr. Lee. That melts my heart because that's what keeps me going. Is that what if these patients never really had a diagnosis? Where would they be? That would hurt me because they don't know. They don't have a doctor that understands their cases. They don't, have someone that champions for them or a team that cares. And so that's really, truly exactly what gets me going.
And I hope AHMG, has the same appreciation as I do, hopefully.
I was anyone from AHMG here? No, it's our team. But no. Yes, we have all physicians are healthcare providers. Thank you. All right, anybody else? Anything else? Any questions? Again, hard cases. So.